everyone, thank you for listening to our case report about flow retriever aspiration thrombectomy, a promising approach to catch a thrombus in transit. This case report is written by myself and Dr. Ayafor and Dr. Matriano Lim from Summa Health System, Akron, Ohio. Clot in transit is a thrombus in the heart chambers, superior vena cava, inferior vena cava, and classified into three categories, type A, B, or C, depending on origin, morphology, and mobility. Clot in transit is associated with 28% of mortality rate, could rise up to 80 to 100% if patient remains untreated. In the cases of clot in transit, it should be treated aggressively with catheter-based or surgical approach to prevent hemodynamic deterioration. Flow retriever is actually the first aspiration thrombectomy system not requiring a cardiopulmonary bypass circuit that was cleared by the FDA for treating right-sided clot in transit. Now let's start introducing about this case. This is a 60-year-old male presented with worsening shortness of breath, chest pain, and right lower leg pain with immobility history for several weeks. There's no history of fever, chills, cough, cancer, travel, or COVID-19 pneumonia. Medical history pertinent for recurrent deep vein thrombosis and pulmonary embolism in 2008 that was treated with 18 months of warfarin. At that time, there was also an IVC filter placement for unclear indication. His initial vital signs were significant for blood pressure of 99/69 and pulse of 112 per beat per minute. His physical exam were unremarkable except for irregular pulse and tachycardia. His EKG showed atrial flutter rhythm with 2-to-1 conduction. His troponin was elevated and his NT-proBNP was also elevated in the 3000. CT chest angiogram show extensive bilateral pulmonary embolism with RV to LV ratio of 2.3. His transthoracic echocardiogram showed global LV dysfunction with ejection fraction of 44%, a right heart strain, dilated inferior vena cava, and an 8.7 centimeter mobile clot in transit in the inferior vena cava extending into the right atrium. Patient was started on heparin drip but remained persistently tachycardic. His hemodynamic instability suggested high risk of massive PE. Therefore, he then proceeded with a right heart catheterization. The IVC and bilateral pulmonary angiography show no remaining clots after being on the heparin drip on the left pulmonary artery. However, it showed a thrombus attached to the apex of the IVC filter and extending into the right atrial caval junction and occluding the basal trunk segment. A picture of that was shown on the next slide. Flow retriever 24 catheters was then used to significantly extubate the clot in transit and reestablish the outflow in the right heart chamber, right atrial, and inferior vena cava. His repeated angiography showed complete resolution of the clot in transit. Post-thrombectomy procedure, an improvement in the pulmonary arterial pressure and clinical symptoms were immediately noted in the patient. Atrial flutter tachycardia persisted, however, post-procedure. Patient was then discharged on the next day in stable condition with beta blocker and lifelong anticoagulant. Patient achieved resolution on cardiac symptoms at his 1-week follow-up and achieved normal sinus rhythm 3 months after discharge. Eventually, he declined to undergo an IVC filter removal. Surgical embolectomy is still considered a first-line therapy for clot in transit, but is associated with many risks and complications. Recent results from FLAME trial has shown very significant and promising results for those people treated with flow retriever compared to other modalities. As you can see, this is a picture of all the components of a flow retriever catheters and how it would help to aspirate the thrombus in the blood vessel. Flow retriever benefits patients with clot in transit and high risk of massive PE when thrombolytics and surgery are contraindicated given its clinically proven lower bleeding risk and shorter length of stay for patients. Percutaneous aspiration thrombectomy in overall should be considered early for prevention of cardiopulmonary deterioration in treating clot in transit. Here are my references and thank you for listening.